Let me tell you about a woman named Dorothy. She was 74 years old, a retired accountant from Illinois, the kind of person who had spent her entire career working with numbers, profit margins, tax codes, quarterly statements. She understood that numbers only tell you something useful when you understand the context behind them. And yet every single year at her annual physical, her doctor would run through a list of test results, say everything looks fine, and send her home with a printout she had never once been clearly explained. Her blood pressure, her HbA1c, her cholesterol, her kidney function number, her resting heart rate. 5 numbers that showed up on every visit. 5 numbers that her doctor glanced at and filed away. And 5 numbers that Dorothy, the woman who had spent 30 years interpreting data for a living, genuinely did not understand in the context of her own 74-year-old body. One day she asked her doctor directly, "What does a GFR of 67 actually mean for someone my age?" Her doctor paused and gave her what she described as the most honest answer he had given her in 15 years. He said, "Honestly, for your age, that number means something quite different than it would for a 45-year-old. And that conversation opened a door that most seniors never find. My name is Dr. Franklin, and today I want to open that same door for you. Every year, millions of seniors sit in examination rooms while a doctor or nurse reads through a list of numbers from their blood work and vital signs. Blood pressure, blood sugar average, cholesterol, kidney function, heart rate. These 5 numbers are among the most commonly measured health markers in all of primary care, and yet the research consistently shows that most patients leave their appointments without a clear understanding of what those numbers actually mean for their specific age, their specific body, and their specific health situation. That gap in understanding is not a small problem. When you do not understand what your numbers mean, you cannot ask the right questions. When you cannot ask the right questions, you cannot be an active participant in your own care. And when you are not an active participant in your own care, decisions get made about your body based on assumptions rather than conversations. Today, I'm going to walk you through what the published research and current clinical guidelines say about each of these 5 numbers, specifically for adults over 65. Not to tell you what your numbers should be, but to give you the context and the questions that will make your next appointment a fundamentally different experience. Before we go any further, I need to be clear. This video provides educational context. It is not medical advice. It does not replace a conversation with your physician, and I will say throughout this video, as I mean it, these numbers need to be interpreted in the context of your complete health history, your other conditions, and your personal goals. That interpretation is your physician's role. What I am giving you today is the knowledge to have that conversation productively. Stay with me through all 5, because number 1 is the number that most seniors assume is the simplest, most black and white measurement in medicine. And the research on how its meaning changes specifically after age 65 is something that continues to surprise people every time they hear it. Drop a comment right now. Are you over 65? Do you know what your 5 key numbers are right now? I read every comment and your answer helps this community. Number 5, your blood pressure reading. Let us start here because blood pressure is arguably the most measured number in all of medicine. Every doctor visit, every pharmacy kiosk, every home monitor. Most people have been told their target is under 120/80, and they assume that number applies equally regardless of age. Here's what the research and current clinical guidelines actually say. The American College of Cardiology and American Heart Association guidelines for adults 65 and older set a target, blood pressure of under 132/80 millimeters of mercury. That is different from the general adult standard and reflects the physiological reality that as arteries stiffen with age, blood pressure readings naturally trend higher and the risk-benefit calculation for treatment targets changes. But here is the dimension most seniors never hear about. The optimal blood pressure target for adults over 65 is not a single universal number. According to a 2024 PMC review on managing hypertension in older adults, for adults aged 65 to 79, the European Society of Hypertension, 2023 guidelines recommend a primary systolic target of 130 to 39 with consideration of going lower if well tolerated. For adults over 80 years old who are functionally fit, the treatment threshold and target ranges differ again. And for adults over 80 who have frailty, the guidelines specify yet another set of considerations entirely. The 2025 Japanese Society of Hypertension guidelines took this even further by formally moving away from age as the primary determinant of blood pressure targets, adopting instead a functional status classification system. Their position, supported by systematic review and meta-analysis, is that a 78-year-old who is fully independent and active may appropriately target the same blood pressure as a younger adult, while a frail 70-year-old may need less aggressive targets to avoid risks including dizziness and falls from blood pressure that is lowered too aggressively. A Cochrane systematic review updated through June 2024, analyzing 8 major antihypertensive trials in adults 65 and older, found that while treatment for blood pressure over 160 millimeters of mercury produced clear cardiovascular benefit, the evidence for applying lower targets universally to all older adults particularly those with frailty, remains an area of ongoing clinical debate. What this means for you is this: your blood pressure number does not exist in isolation. It means something different at 68 than it does at 82. It means something different if you are physically active and independent than if you have balance concerns or frailty. And the question you deserve to ask your physician is not simply, is my blood pressure normal? The question is, given my age, my functional status, and my other health conditions, what is the right blood pressure target for me specifically, and why? Number 4, your HbA1c, the 3-month blood sugar average. The HbA1c test measures what percentage of your hemoglobin, the protein in red blood cells, has glucose attached to it. Because red blood cells live for approximately 3 months, the result reflects your average blood sugar control over that period. The standard clinical diagnostic threshold used across all adults is under 5.7% for normal, 5.7 to 6.4% for prediabetes, and 6.5% and above for diabetes. Here's what most seniors never hear. Those thresholds were established based on reference values derived in 1986 from a population of 124 non-diabetic individuals aged 13 to 39 years. As a BMC endocrine disorders study published in 2019 documented, these reference values have not been updated since then, despite multiple studies showing that HbA1c levels rise naturally with age in non-diabetic individuals as a consequence of physiological aging processes, including reduced insulin sensitivity, declining muscle mass, and changes in red blood cell turnover. This means that a 70-year-old whose HbA1c measures 5.8% would technically fall into the prediabetes category using standard thresholds, even though research shows that the average HbA1c for healthy non-diabetic adults over 65 is itself slightly higher than it is for younger adults. Context matters enormously. The American Diabetes Association, the American Geriatric Society, and the International Diabetes Federation have all made age-specific adjustments to HbA1c target ranges for adults over 65. For healthy, functionally independent seniors with diabetes, the ADA recommends an HbA1c target of under 7.5%, recognizing that maintaining levels under 7% requires more intensive management that carries a higher risk of dangerous hypoglycemia. In older adults, for seniors with multiple complex conditions or limited life expectancy, the guidelines allow targets up to 8% or even 8.5%, prioritizing quality of life and safety over strict glycemic control. A PMC study found that when age-dependent HbA1c therapeutic targets were implemented, the odds of appropriate medication de-intensification in older adults with diabetes increased significantly, meaning seniors were more appropriately treated when their targets were adjusted for age, rather than applying a one-size-fits-all threshold. What this means for you: if you have had an HbA1c result that concerned you or that your doctor said was in the pre-diabetes range, ask these specific questions. How does my result compare to what is expected for my age? What target range is most appropriate for my health status and my individual goals? Is aggressive blood sugar management the right priority for me specifically? And what are the risks of both overtreatment and undertreatment? If you are still with me and finding this valuable, type the number 4 in the comments right now. It helps this information reach more seniors who need it. Number 3, your total cholesterol and LDL numbers. Cholesterol is perhaps the health number most surrounded by oversimplification. Most seniors have heard, lower is better. Keep your LDL down. Watch your total cholesterol. And for many adults in many circumstances, that guidance is appropriate. But the research on cholesterol in adults over 70 carries important nuances that most patients never hear. Here is what the published evidence shows. Multiple large observational studies have found what researchers call the cholesterol paradox in the elderly. A 2015 analysis published in BMJ, open that reviewed 19 cohort studies involving nearly 70,000 adults over 60 found that high LDL cholesterol was not associated with increased cardiovascular mortality in elderly subjects, and was in fact associated with lower all-cause mortality in the majority of studies reviewed. The researchers proposed that in very old adults, cholesterol may have protective functions related to immune response and hormonal function that are not captured by the cardiovascular risk models designed for middle-aged populations. This does not mean that cholesterol management is unimportant in older adults. It means that the interpretation of cholesterol numbers and the decision about whether and how to manage them in adults over 70 is significantly more nuanced than the simple lower is better message most seniors receive. Current guidelines from multiple cardiology organizations recommend that cholesterol management decisions in older adults be individualized, taking into account cardiovascular disease history, frailty, life expectancy, patient preferences, and potential medication side effects. The American College of Cardiology and American Heart Association 2019. Cholesterol guidelines specifically note that for adults over 75 without established cardiovascular disease, the decision about cholesterol treatment should involve a clinician-patient discussion about potential benefits and risks rather than applying a universal threshold. What this means for you: if your cholesterol numbers have been flagged, ask your physician, given my age and my overall health status, what is the actual clinical significance of my cholesterol level? What does the risk-benefit calculation look like for my specific situation? This is a conversation that your numbers alone cannot answer. Number 2, your eGFR, the kidney function number. This is one of the most commonly misunderstood numbers in senior health, and the research behind its age-specific interpretation is among the most clinically significant things I will share in this entire video. eGFR stands for estimated glomerular filtration rate. It measures how efficiently your kidneys are filtering waste from your blood. The number is expressed in milliliters per minute per 1.73 square meters of body surface area. The standard clinical threshold used to define normal kidney function is an eGFR of 60 or above. Below 60, maintained for 3 months, with other markers of kidney damage, is the diagnostic threshold for chronic kidney disease. Here is what most seniors never hear. eGFR declines with normal aging at approximately 1 milliliter per minute per year after age 40. This means that a healthier 70-year-old with no kidney disease whatsoever should be expected to have a meaningfully lower eGFR than a healthy 40-year-old with identical kidney health. Research shows that healthy people in their 60s have an average eGFR of approximately 85, and healthy people in their 70s have an average eGFR of approximately 75. The standard reference range labeled normal in most lab reports is 90 or above, which means that the majority of healthy older adults are automatically flagged as having suboptimal kidney function simply because of their age, not because of any actual kidney disease. A 2024 Kidney International reports analysis stated directly that applying a single eGFR threshold of 60 milliliters per minute to all ages results in overdiagnosis of chronic kidney disease in the elderly, and that an age-adapted definition reduces the apparent prevalence of CKD in adults over 65 by as much as 50%. A large Italian population-based study involving 325 622 individuals aged 65 and older found that more than 40% of patients classified as having chronic kidney disease by standard criteria actually met criteria for renal senescence, meaning normal age-related kidney function change rather than true disease. This overdiagnosis has real consequences. It can lead to unnecessary anxiety, additional testing, dietary restrictions, and medication changes for a condition that may represent normal aging, physiology rather than pathology requiring intervention. What is clinically important, according to the research, is not a single eGFR reading, but the trend over time. A stable eGFR of 68 in a 72-year-old over 3 consecutive years carries a fundamentally different clinical meaning than an eGFR of 68 that has dropped from 85 over the same period. What this means for you: ask your physician, what was my eGFR at my last 3 annual tests? Is it stable or trending downward? Given my age, is my current eGFR consistent with normal physiological aging, or does it suggest something that warrants further evaluation? And is urine albumin being tested alongside my eGFR? Because that combination is the most sensitive early indicator of genuine kidney stress. Number 1, your resting heart rate. I told you at the beginning that this one would surprise you, because resting heart rate is the number that most seniors and most doctors treat as the most straightforward measurement in the room. A resting heart rate between 60 and 100 beats per minute is normal. You are told that at every visit, and then the conversation moves on. Here is what that simple statement is missing. The research on resting heart rate and all-cause mortality, specifically in adults over 65, reveals a relationship that is far more informative than the basic normal range suggests. And it is a relationship that most seniors are never told about. A landmark study published in the Canadian Medical Association journal that followed 798 adults over 15 years, with analysis specifically relevant to older populations, found that higher resting heart rates within the technically normal range were independently associated with higher mortality risk. Adults whose resting heart rate was consistently in the upper portion of the normal range, meaning 80 to 99 beats per minute, faced significantly higher cardiovascular mortality compared to those whose resting rate was in the lower portion of normal, meaning 50 to 70 beats per minute. A 2019 systematic review in Heart, the Journal of the British Cardiovascular Society, analyzed data from multiple longitudinal studies and found that for every 10 beat increase in resting heart rate, all-cause mortality risk increased by approximately 9% and cardiovascular mortality by approximately 8% in adult populations. The reason this matters specifically for adults over 65 is that a resting heart rate that is technically within the normal range, but sitting at 85 beats per minute year after year is not the same as one sitting at 62 beats per minute. Both are normal by the simple binary standard most people hear, but they do not carry the same long-term cardiovascular implications. And more importantly, a resting heart rate that is trending upward over several annual visits, even while remaining in the normal range, can be an early indicator of cardiovascular deconditioning thyroid changes, anemia, sleep-disordered breathing, or cardiac rhythm changes that are worth investigating. The additional dimension that most seniors never hear is this. Resting heart rate is highly modifiable. Multiple well-designed studies have found that consistent aerobic activity, even gentle walking over months to years, produces measurable reductions in resting heart rates through a process called cardiac autonomic adaptation. The heart becomes more efficient. Each beat pumps more blood, and the resting rate drops, not because anything is medically wrong, but because the cardiovascular system is being maintained through consistent use. What this means for you: at your next appointment, ask your physician, what has my resting heart rate been over my last 3 to 4 visits? Is it stable or trending in any direction? And is there anything about my current resting rate or its trend that you think is worth discussing in terms of cardiovascular health or lifestyle? That question takes 30 seconds. The information it can generate is invaluable. Dorothy, the retired accountant, left her appointment that day with something she had not had in 15 years of annual physicals. She had context. She understood that her GFR of 67 was stable, consistent with her age, and not a reason for alarm unless it started declining. She understood that her HbA1c target was appropriately higher than it would be for a younger adult given her health goals. She knew her resting heart rate trend was something worth watching, and she left with 4 specific questions written down for her next appointment. She told me later that the 30 minutes she spent understanding those 5 numbers changed her relationship with her own health more than anything else she had done in a decade, not because the numbers changed, but because she finally understood what they meant. You deserve that same understanding. Every number on your lab report has a story, and that story changes with age in ways that the standard reference ranges on your printouts do not always reflect. Here is your action step. At your next appointment, bring a piece of paper with these 5 questions. What is the trend in this number over my last several visits? Does the normal range change for someone my age? Given my overall health and my personal goals, what does this number actually mean for me? Is there anything about this result that would change what we are currently doing? And what would you want me to watch for between now and my next visit? Those 5 questions, applied to your 5 numbers, will make every annual physical you have from this point forward a fundamentally different conversation. If this video gave you something important to take to your next appointment, please subscribe. I make videos like this every single week. Evidence-based, honest, and built specifically for adults over 60 who deserve real information about their own health. And leave a comment below. Which of these 5 numbers have you been most confused about? Your answer might be exactly what someone else watching today needed to hear. Take care of yourselves. I will see you in the next one.